Thank you, everyone, for joining us today. I'm really excited to introduce to you our speaker, Dr. Avindra Nath, who is the clinical director and the chief of the section of infections of the nervous system at the National Institute of Neurological Disorders and Stroke at NIH, positions he's held since 2011. Prior to he was professor of neurology and director of the Division of Neuroimmunology at Johns Hopkins University. He was previously the president of the International Society of Neurovirology. He conducts clinical and bench research on understanding the mechanisms by which viruses affect the brain and develop new methods for diagnosis and treatment of these infections. So I think we'll just go ahead and jump right into our discussion. So our first question I have for you is multiple sclerosis due to a viral infection?
Yeah, thanks, Hannah, for having me on this show and for engaging me in this interview. It's a real pleasure to have the opportunity to talk about something that I'm really passionate about at the same time. And the idea that multiple sclerosis could be caused by a virus has existed for a very long time. And people have isolated viruses from patients with multiple sclerosis over the years and over several decades. The only problem is that every time we've isolated one, then there are another set of groups that come back and say, well, we can't reproduce it. Or maybe this was some contaminant, or maybe these viruses just exist in humans and you just keep finding them. That doesn't necessarily mean they cause the disease. So far, the evidence that a virus actually causes multiple sclerosis is rather weak, although there's been a lot of renewed interest in that possibility because of some recent papers implicating a virus called Epstein-Barr virus and the possibility of driving multiple sclerosis. That idea has existed for a long time, but there are additional new data suggesting that we need to take a closer look at this possibility.
Okay, great. That brings me actually to our second question. If MS is caused by a virus, can it be cured if the virus can be treated?
Yeah. So that's a very, very important issue to talk about. Okay, so if we develop the common cold or COVID, for example, what have you, and we think that, okay, if we use an antiviral drug, that should solve our problem, right? Same thing of any bacterial infection that you have. If you were to treat it with an antibiotic, that gets rid of the disease. And people who are really keen to find viruses in these kinds of diseases are of the same thought process that if you could find the underlying infectious etiology, we can probably cure the illness. One has to look at these things carefully so that these viruses that we're implicating are actually ones that infect in large populations. For example, Epstein-Barr virus infects the majority of the population on the planet, and it infects it at an early stage of one's life. So, but not everybody develops multiple sclerosis, right? So if you now have a select population that are developing it, let's say you give them an antiviral drug and you get rid of it. Well, the virus still exists in your community. You'll just get reinfected with it, right? So you may never be able to get rid of it that way, not with an antiviral drug. Now, the other flip side, you can say, okay, well, if you can't do that and people are going to get reinfected, what about creating a vaccine? If we were to create a vaccine, maybe what we can do is prevent the infection from taking place. That is a possibility, but in order to do so, you would have to vaccinate 8 billion people on this planet, right? A huge population to actually prevent it happening, because you don't know who's going to develop multiple sclerosis. Certainly there's certain populations you could probably predict who have a lot of family history of MS and stuff like that, but the vast majority of them are sporadic. So if you're going to make a difference, you got to vaccinate a huge population. That's not an easy task to do. So even if one were to find a virus, it is still very challenging as to how you're going to prevent the disease from occurring.
Can patients with HIV infection also develop multiple sclerosis? And then secondly, will they be treated differently?
So that's an interesting thing to think about. And so what HIV does is it suppresses one's immune system. So if you thought that it was a virus that is causing MS, then you would think that virus would now be able to replicate unchecked because the immune system is suppressed. Right? And so all immune suppressed individuals, whether you have HIV or you have cancer or you have some kind of autoimmune disease and you're being treated with various kinds of immune suppressive drugs, you would think that all of them would be at increased risk of developing multiple sclerosis. Well, if you look at the epidemiology, that doesn't seem to be the case. It's not that we see more MS in patients who are immune suppressed. Right? That doesn't seem to be the case. In fact, there's an interesting study in HIV patients whereby what they did was they looked at the epidemiology of multiple sclerosis in HIV individuals, and they found that if they were on antiretroviral therapy, there was a somewhat of a decreased incidence of multiple sclerosis, right? Not increase. So then they thought, okay, well, maybe what it is the antiretroviral drugs are somehow suppressing the multiple sclerosis itself, and maybe it has broader effects. So they did a small study in MS patients. It didn't seem to make a difference, but there's still renewed interest in trying to see if maybe we should give those kinds of drugs to MS patients and do a proper clinical trial to see if it makes a difference or not. So it's quite fascinating as to how there's interaction between these viruses and how the drugs that you may develop for one treatment can actually interact with the other. But all these things need to be sorted out.
Definitely a very important topic for sure. Number 4, since patients with MS are treated with drugs that suppress their immune system, could it allow the virus or viruses to get activated and cause harm?
Yeah. So that in part is true. We've seen, for example, with natalizumab, what happened is that when it first came on board, people became aware of the fact that this opportunistic infection called PML, or progressive multifocal leukoencephalopathy, which is caused by a virus called JC virus, it started to emerge in these MS patients. And nobody had ever seen PML in the context of multiple sclerosis. And now over the years, it has become quite evident that the drug prevents the trafficking of these immune cells into the brain. And by preventing that from taking place, you have the JC virus that gets reactivated, and then it can manifest as PML in the brain, and actually can be quite devastating and fatal in some individuals. Same thing with a number of the other drugs. We've seen opportunistic infections. Shingles will sometimes show up in patients with multiple sclerosis on immune suppressive drugs. And they are, as you know, quite prone to developing urinary tract infections and pneumonia and the like. And if you have them on immune suppressive drugs, the chances of those kinds of infections is also high. So one has to weigh the pros and cons of these drugs. Certainly, they're very effective in controlling multiple sclerosis. So you wanted to control the disease. But at the same time, you have to be vigilant to follow patients very closely to make sure that they're not developing some kind of a opportunistic infection.
Yes, definitely all good points. Our 5th and final question, are MS patients on immunomodulatory drugs more likely to develop infections? If so, which ones?
Okay, I think in part we addressed that already. The immune modulatory drugs, so there are different types of immune modulatory drugs that we have for patients with MS. For example, if you have the beta-seron, Copaxone, some of these older ones, there was no increased incidence of opportunistic infection there, because what they were doing is they were just rebalancing the immune system, but they weren't really suppressing the immune system. We have some of these newer ones, for example, rituximab, and ocrelizumab, they get rid of the B cells completely. So you have a whole arm of the immune system now doesn't exist. So, and you need that to control other kinds of infections. Fingolimod, for example, what that does is that traps the T cells into the lymph nodes. And so they're not available now in circulation to fight off other kinds of infections, right? And natalizumab, and what it does is it prevents the T cells from getting into the brain. So your brain is now vulnerable getting infections. So if you have an understanding of the mechanism as to how these drugs work, you could in some ways predict the types of infections that may or may not occur in patients with multiple sclerosis. A good example is COVID, for example. And here, what happened is that patients who were on the B-cell therapies, and they fared worse once they got COVID, and they were more likely to develop COVID. So both things have happened to them. And that became a bit of a challenge. But for some people, those are the kinds of treatments that are keeping their disease at bay. So then we had to balance the vaccines. So we said, okay, now the vaccines have become available. Maybe if you get vaccinated, you won't have to worry about the COVID part and you can take these things safely. Well, you could obliterate the effects of the vaccine with these drugs too. So now what is really critically important is the timing of the vaccine. So you don't want to give it when you have the maximal effects of the drug that you're giving, but rather you want to give it at the time when the drug is losing its effect and they're ready for the new dose. So prior to that, you want to vaccinate people, give them a little bit of time to develop immunity. Then after that, you suppress them. Then the B cells, that the memory cells that are there that are generated from the vaccine will still be there. Okay. For example, you have measles, rubella, and other kinds of vaccines you received in your childhood. When we put you on these drugs, we don't have to now revaccinate people because those memory T cells remain entrenched and we're not losing them by these treatments. So vaccination is still the key to prevention of infections.
Yes, vaccinations are very important. Thank you so much for your time today, Dr. Nath. I believe that's all of our questions. And thank you everyone for tuning in. I hope that this was beneficial on your journey. Thank you so much.
Well, thanks for having me. I really enjoyed it, Hannah. Bye-bye.